Hello everybody, my name is Stavros Pelekanos, coming from Athens, Greece, and teaching at the University of Athens in the Prost department. So we are going to be talking about the role of prosthodontics in preservation of soft and hard tissue around implants. The question is tissue stability. I can show you hundreds of cases like this, nice cases with nice transmucosal contour. Again, the question is how stable can this be through time? So in the next 40-45 minutes, we are going to be focusing into answering to some questions like how deep should the implant be placed? And this is something that has to do with the kind of implant that we place, the kind of abutment, if the implant is rough to the top or has a collar which is polished. So this is something that will guide us in which position should we place the implant regarding depth. And of course, what kind of size of abutment should we use? This is another question. And last but not least, what is the treatment sequence? This is a case, the previous case which you saw, this is a case with a central incisor positioned in place, and the radiograph after 5 years down the road looks stable. As we know, most of the changes happening in the implant rehabilitations are in the first 2 years. So usually after 2 years, when I see this stable condition in an implant rehabilitation, I'm happy and pretty sure that this is going to last for the next years. And the radiograph, in this case, we see an implant, a screw retained restoration at the implant level. Maybe some bone resorption in the first 1.5 millimeters, as you see here. So what do we know today? First of all, we have to know and to be aware regarding the differences between implants and teeth. And as you can see here in this table, the main differences are connection. So we have cementum, bone, and periodontal ligament around teeth, and we have osseointegration, which means direct contact between the bone and an implant around the implants. But the most important difference is the connective tissue. We have perpendicular fibers penetrating the cementum, as you see in the left side of the tooth here. Whereas in the around implants, we have parallel fibers. So we don't have fibers from the connective tissue penetrating the titanium. Very important is that when we compare the biologic width around teeth and implants, that we have a biologic width around implants which is greater. We know that around teeth we have nice studies and old studies from Carguillo and Vacek that we have the biologic width around teeth is approximately 2 millimeters. But when we go around implants, these numbers are greater. It is between 3 and 4 millimeters. And of course, we know from the literature and from the history until now, the most biocompatible materials as abutments that we can use are titanium and zirconia. This is almost 10 years old study from Wielander and co-workers, which show in beagle dogs that we have a better response of the soft tissue when we use zirconia or titanium. I could find one study on humans, one from Tomasi, which was published about 3 years ago, where he put titanium abutments, and then he took biopsies, which were like at 8 weeks after abutment placement, and he could show that there is a barrier, a soft tissue barrier of approximately 3.6 millimeters which is almost pretty much the same with what we find in animals. The half of it was connective tissue, so 1.97 was connective tissue, and the half of it was epithelium. And also we have some histological evidence from the Nevins group, where we could find in abutments that they were roughened, the laser lock abutments. We could find histological evidence of connective tissue integration on these rough abutments. So having an implant rough to the top, it's beneficial, and let's see if we have an implant rough to the top and in a situation which is a scalloping situation like in the aesthetic zone, we know and we understand that in some places the implant is placed subcrestally. So having an implant rough to the top is beneficial for a scalloping situation like we have in the aesthetic zone, and also it's also beneficial for the augmentation procedures, which is also very often in the aesthetic zone. In the images here you see an immediate implant placement into extraction socket. So it is beneficial to have a rough to the top implant in the aesthetic zone, but on the other hand, we have a greater running room for the abutment in the soft tissue, and this could be difficult in the designing of the abutment. And of course, because of that, and because of the rough surface, we have a possible peri-implant inflammation, and this could be the drawback for this situation. So implant positioning, and having an implant rough to the top, we understand that this might be beneficial for the aesthetic zone, because in the aesthetic zone we have a scalloping situation, which means we know from the literature, from Spears, Coyce, and others, that there is a scalloping in the aesthetic zone of approximately 2 to 2.5 millimeters, which means that when we place an implant epicrestally or slightly subcrestally in the extraction zone, like you see here, mesial and distal, we have the implant placed subcrestally. And this is good when we have an implant rough to the top, and also it is beneficial for our augmentation procedures. But on the other hand, we have a bigger running room, which means that we have a running room of approximately 3.5 to 4 millimeters, and we have to take care of it. And because of that, the same positive rough to the top surface could be negative because of possible peri-implant inflammation. So we have positive and negative things. So how many solutions we have for the crown abutment complex? So we have categorized the possibilities, and we can have a screw retained restoration traditionally at the implant level, like you can see here in this diagram, or we can have a screw access hole which is slightly changed of approximately between 10 to 12 degrees, which means that we can still screw the abutment or the crown at the implant level with a slight inclination. We can have a screw retained restoration, which is screw retained not into the implant but onto a mesostructure, or a horizontal screw, which we don't use anymore. Or we can have a traditional cement retained restoration, like you see in this diagram, on a straight or an angled prefabricated abutment or customized abutment. And we can also have, if we don't have the possibility, or we have a slight inclination or a bigger inclination to use the veneer abutment, or we can use the cement screw retained restoration, where we do one abutment disconnection, we cement extraorally. In this lecture, we will be focusing into the screw retained restoration on the mesostructure and into the veneer abutments. There is another categorization, a decision chart, which you can see here according to the gingival morphology, what we choose when we have flat or scalloped situation, or when we have a thick or thin biotype, and of course according to the implant inclination. And we have three categories: ideal implant inclination, less than 15 degrees or more than 15 degrees, and you can follow here in this chart the decision chart for the abutment crown complex. What about the gap? Let's start with the gap. The gap, we know that there is no perfect gap. We have bacterial leakage that occurs in any implant abutment interface, irrespective of the type of the connection, and this we have to accept. You see here in a clinical study from Canulo and co-workers, after 5 years of functional loading, none of these connections could prevent microbiological leakage. So there is no perfect leakage. Even famous conical connection fail, and this failure is also more during function, like you see here in this small experiment. So what are the factors that determine the soft and hard tissue stability around implants? So we have pretty much, restoratively speaking, first of all, a scalloping situation. You see the green line here. The interface seal and the micro movement is very, very important, and this is what we already have mentioned. The distance between the abutment and the adjacent tooth is also very important. And we'll see if we have a proximity between an implant and the abutment, then there is a reason to use a platform switching concept. And this is, for me, the most important reason to use a platform switching concept, especially in single implants. And last but not least, the prosthetic design, the abutment configuration, and the shape of the abutment and the treatment workflow are very, very important. We know the traditional approach. We have, everybody has done this, a traditional approach with a screw retained restoration made out of acrylic, when we connect and disconnect every 10-15 days, and we are creating the emergence profile with the help of this traditional, of this screw retained restoration. And once we have created the emergence profile, what we do is that we copy this, and this is the final transmucosal contour. We copy this and we proceed to the final restoration. We give this information to the dental technician and we proceed to the final restoration. This is still the gold standard. It's already described and written already in the literature, the immediate definitive abutment concept, connection at the second stage surgery. And this is in an article that we have published together with Sasha Jovanovic and co-workers, International Journal of Periodontics and Restorative Dentistry, where we describe the immediate definitive abutment connection at second stage surgery. In all these cases, we had to cement. And of course, we know that the cementation gap is always a problem. Once a cement is going into this transmucosal contour, it's almost impossible, even from the best clinicians, to clean the abutment. So we know that actually, like in this case you see in this small video, most of the times we have three gaps in the transmucosal contour. The first gap is a mechanical gap, which is the gap between the implant abutment, the metallic sleeve, and the implant, which is at the implant level. And we have two cementations gap. The first cementation gap is the gap between the zirconia or ceramic abutment and the metallic sleeve, the metal sleeve. And the last gap is also cementation gap in case we use cement retained restoration. So actually we have three gaps in a very, very sensitive area, such as the transmucosal contour. I would like to show you an old concept revised. And the concept is that, and this concept we are trying the last 3 years, and we have already 20-25 cases, and it seems promising. So the concept is that we use an intermediate abutment, the so-called multi-unit abutment, but the multi-unit abutment, actually it's not the right word to use, because we are using the same concept for the single implant restorations. And we immediately connect this abutment one time. So I'm going to show you this in a few cases. Case number 1, we have the tooth number 21, the central incisor. We have external root resorption. So we had to extract this tooth. And basically, we are going and digitally plan the implant placement, as you can see here. Again, it's very important that the implant is placed at a distance of 4 millimeters between the clinical crown and the implant head, and of course in an angulation that the access hole is coming in a palatal way. In this case, we use the M-guide, and it's very, very important when you use a guide stent like this that the metal sleeve is positioned apical as possible, so we have a very, very precise position of the implant, and we don't have a big deviation. Also, the implant is placed through the stent. So practically we have an immediate implant placement in the extraction socket. We had a thick biotype in this case, and we have intact the facial bony wall, which means that we are in the favorable position to do that. At the same time, we insert the immediate intermediate abutment, the so-called multi-unit abutment, but for single restoration, because we are able to have anti-rotation in the crown. And as you can see here, we fill the gap with some xenograft, some Cerabone in this case. We had the 20 newtons per centimeters, which means that we are able to load this implant, and we do the immediate provisionalization at the same time. Practically, in order to make clear what kind of abutment we use, is when we insert the implant immediately or delayed. When we have these 30 newtons per centimeters, then we go for immediate provisionalization. If I don't have this torque, the final torque, then, but still I cannot rotate the implant with my hand, then I'm going for a healing abutment or for the immediate intermediate abutment, and but we are not loading the implant. If I can turn the implant with my hand, which means that approximately my hand can reach maybe 10-12 newtons per centimeter, if I can still turn the implant with my hand, then I don't load it, I don't put any abutment, and we are going to cover the implant. So this is the concept that we are using in our office. So the concept is that we don't remove the intermediate abutment, which is at a height, usually in the front area we use a 2 millimeter intermediate abutment, and we are not interfering with the bone and the soft tissue, which is very, very close at the implant head level. Yet you can see here in the green light. So practically, we follow the placement of the 2 millimeter abutment, like you see here. So, and then if we say that we have a 4 millimeter running room from the implant head to the clinical crown, these 2 millimeters, we put the immediate abutment and we don't touch it anymore, which means that we are going to play, let's say, with the emergence profile in the last 2 millimeters of the transmucosal contour. And this is between these two red dotted lines. So in these lines, we can push the soft tissue or we can avoid pushing the soft tissue according to the clinical case. There are some cases, for example, that we don't push, we don't push at all. And then we are coming like with a 90-degree design. Okay, this is not so very common, but in this case where we have a thick biotype, then we are able to do the 90 degree abutment design with no pressure. And of course, this is something that we do, like you see in this small video, only when we have a thick biotype, again, and a patient that really can clean, because we have, let's say, a vertical pocket. But in this case, in the cases where we have a thick biotype and a patient that cleans, then we are able to do it. Of course, it's possible, and what we do, we use this technique, that the immediate intermediate abutment concept, also for cases where we have GBR, a guided bone regeneration procedure, like you see in this case, where we have two laterals missing and we place the two implants. You see the concavities and the bone missing in the labial surface of these implants. Again, we had the 30 newtons per centimeters. We immediately connect the intermediate abutments, and at the same time we are doing the GBR procedure, the guided bone regeneration procedure with Cerabone. This is the occlusal view before the augmentation procedure. You see the positioning of the two laterals and the positioning of the two immediate intermediate abutments. In this case, we didn't have the 30 newtons per centimeters. We didn't proceed for immediate loading, so we covered the immediate abutments. We used them as a cover screw. 6 months later, we proceed with the provisionalization. And you can see here in this small video some details during the healing phase. We don't remove the intermediate abutments. This is one abutment, one-time concept. And now we are playing, let's say, with 2 millimeters, which is close to the clinical crown, like you can see here. Again, bone and soft tissue preservation, you can see here in the radiographs. We don't remove the pins. Using the immediate intermediate abutment concept in a case with a guided bone regeneration procedure. Of course, there are some cases where we are not able to put the implants immediately, so we have to go in a stage approach. A method that we are using the last 2 years, and we are working on it, is the socket preservation after the extraction using a mixture of xenograft and emdogain. So emdogain seems to to act positive in the in the bone formation during the wound healing. And this is a case where we extracted 4 central incisors. We put this mixture immediately of the xenograft and the Emdogain, and we put a fixed provisional restoration, which is like a Maryland bridge. So this is at day 1, and this is at 10 days after the extraction. This is at 20 days after the extraction, 30 days. We see some xenograft particles in the area of the extraction socket. So what we do now is that we go early, relatively early, and we place the implant. We have done some cases together with the University of Berlin. So at 4 months we go inside, we place the implant. You see the implant planning, the computer navigated implant placement, and a small video. So again, I repeat, it's early. What we do in these cases is that we take the small part of the soft tissue at the implant placement. We are going to place 2 implants, and we take biopsies. This is at the position of the central incisor, like you see here, and this is at the position of the lateral incisor. So my feeling in these small number of cases that we have done the last couple of years is that we have, it's relatively hard. So implant placement through the guide stent, of course. No use of soft tissue graft. No use of bone graft in this case. I go a little bit faster, of course, and at the same time, the same concept applying of the immediate intermediate abutments. In this case, is going to be a fixed bridge, a fixed partial denture. And you see here the placement and the final torque at 30 newtons, which means that we can deliver the immediate restoration at the same time. So we do immediate provisionalization. So actually we place the implant, we place the immediate intermediate abutment, we do the immediate provisionalization, and everything is done at the same day. And you see here the final X-ray. So until now, what we have seen, and here you can see a biopsy coming from the Charité University of Berlin, and we can see some active osteoblasts and some cerabone granules around a new built bone, like you can see here. And this is about 10 weeks after implant placement and provisional placement. So I repeat, is immediate implant placement, not immediate. Early implant placement, 4 months after extraction, immediate intermediate abutment connection, and immediate provisionalization. No bone graft and no soft tissue graft. So finalizing, I would like to present to you the veneer abutment. The veneer abutment is an abutment that we use. Actually, we cement a veneer onto the abutment, which is screw retained on the implant. for two reasons. Reason number one is in cases that we don't have an ideal inclination of the implants. So we screw retain the abutment and then we cover, let's say, the screw access hole with the veneer, the ceramic veneer. But the most important indication is when we want to match the colors between veneers, or when we apply also veneers, or we do prosthesis also in the neighboring teeth. Like you see here in this case, the last case, we have a socket. In this case, we extracted the tooth. We did an immediate implant placement. We also use the socket seal technique, which means that we use a part of the root of a technique that is described by Mark Hürzeler and Otto Zur from Munich. So at the same time, we put the immediate intermediate abutment. And of course, you can see here in the small video the procedure. So it's digital planning in the computer. Again, we use, in this case, the M-guide. Very, very careful sectioning and extraction of the palatal part of the root, like you can see here. And of course, we reduce the height of the buccal root. And now we are going to place the implant with the help of the M-guide, the stent. You see every drill has a stop, so we are placing the implant in a very, very close proximity, actually in contact with the root. We have 30 newtons per centimeter, which means that we can proceed in immediate provisionalization. But before that, we are placing the immediate intermediate abutment, like you can see here. We torque this abutment one time. We don't remove this abutment anymore. We don't want to have any interference with bone or with the root in this case. And you can see the immediate provisionalization. We connect with some flowable resin, and we are able to screw retain the immediate provisional crown. In this case, the implant is positioned in the correct position, which means that we don't use the veneer abutment for the correction of the access hole, but we want to match the color between the implant crown and the adjacent veneer. So, and this is the veneer abutment. And as you can see here, the lab is Nondas Vlachopoulos from Athens, Greece. We proceed for lithium disilicate veneers in the neighboring teeth, the two laterals and the central. And a small video showing this abutment. We unscrew the provisional restoration. We have already we are finished with the veneer preparation in the neighboring teeth. You see the nice transmucosal contour, the immediate intermediate abutment, the veneer abutment in place, which is screw retained. A palatal view. So with this veneer abutment, we are able to have the same distance, the same color, the same space for the dental technician in order to be able to manufacture the veneers. Just before cementation, we are putting retraction cords for the cementation. Of course, the cementation of the veneer can be done also outside of the mouth. So we don't have to do the cementation in the mouth. So we have lithium disilicate in the veneer and lithium disilicate in the abutment, which means that we can acid etch with hydrofluoric acid, both of them, and the whole procedure is done outside of the mouth. So now we are able in this way to clean outside of the mouth, so we don't have any remnants of the cement in the transmucosal contour. We position the abutment, and now the cementation of the veneers is following. And some final images, and you can see here the final restorations: a screw retained restoration, veneer abutment at the central incisor, at the left central incisor, and 3 veneers at in the neighboring teeth, and the final frontal view, and the happy patient. So finalizing, we have already it's already accepted for publication. The concept that you have seen in this small lecture, the immediate and the title is the immediate 2-piece low-profile abutment as a means to enhance peri-implant and hard tissue stability in the aesthetic zone. It's accepted for publication. We have done more or less 20-25 cases in the last 2 to 3 years, and it seems to be very, very promising. We have really stable results in a way that with the abutment we are not interfering with the soft and the hard tissue at the implant head. To summarize, the preservation of soft and hard tissue around implants is multifactorial, which means that we have to have a system which has a very good seal between the abutment and the implant, very, very small very small implant abutment micro movement. The implant tooth proximity is also very important, and for me this is the most important reason to do a platform switching concept in order to avoid bone resorption in mesial and distal from the implant in the spaces where we have the papilla. And of course, when we discuss screw versus cement retained restoration, we are going for prefer screw retained restoration. The treatment workflow, as you saw, is very, very important. The one-time intermediate abutment concept combined with the transmucosal contouring might be beneficial for the soft tissue stability, and of course the clinical handling and the technician's ability are also very important. Thank you very much.